Hope you're doing well. This is another lecture that I'm going to try to do every week so I can review the textbook because our PowerPoint will be a little bit different. I'm trying to combine the information so it's not confusing and it makes sense to you. So this week we're on Chapter 10 in your Cengage textbook. I think Chapter 10 was really interesting. I just read it, Professional Ethics in the Living. There are a lot of interesting pieces of information that I think you can find in here that will help you in regards to understanding kind of the means of what ethics is in healthcare. So when you start out on page 236, I really think it's interesting, and I think this is 100% true. It talks about the allocation of scarce resources in healthcare. When we went through COVID-19, there was a lot of places that shut down because of the billing requirements and such. So I'll give you an example of this. Many hospitals couldn't deliver services that they normally could, and in turn had to shut their doors. So it's been challenging to get people seen in a timely manner because of the financial situation involving COVID-19, and also the challenging situation of being able to care for those who had the disease itself. So as we look at different situations, I can give you examples of where I'm at here in Olympia, Washington, where our ER has a wait time of 4 to 6 hours. And there's many countless places like this. So keep that in the back of your head when you're reviewing this chapter. You know, ethically, we want to do what's right for the patient, but we also have to keep the doors open as well. So there's a fine balance there when we talk about the amount of resources that a hospital or a clinic or any kind of healthcare organization has. There's also a great kind of case study on page 237 about conflicts in the intensive care unit. I would recommend you read that, and it really gives you a kind of a brief example of what people have gone through over the last few years. Managed care is also another concept. You know, when we talk about managed care, you look at the difference between fee-for-service and value-based medicine. So we're moving into a value-based medicine field for the majority of the United States. However, we're still entrenched in fee-for-service. So the difference between value-based medicine and fee-for-service is fee-for-service, you come in, you get something done, you have a procedure done as a patient, you're paid based on that procedure. It's just in and out kind of thing, paid based on what you do. In value-based care, they take a look at the person as a whole and pay an organization a flat rate to take care of that person for a given year, as an example. It could be annually, sometimes it's quarterly, just depends on how the payer is structured. And when I say payer, I mean insurance payer. So value-based medicine is a flat rate for an individual that's cared for. So in that model, a patient would want to stay out of the hospital. Well, an organization would want to keep the patient out of the hospital. I know we've talked about HMOs and PPOs. A PPO would be a fee-for-service model, and I know we talked about that last week. But in the value-based model, you're paid a flat rate. You want to take care of them in an outpatient setting because that's the cheapest setting, and you want to keep them out of the hospital so they don't run up the cost of care. So that's the goal of a value-based system. And we'll talk about that on page 238. And I would recommend reading Ethical Conflicts Created by Managed Care. So there's some interesting components in there. Another case study on page 241 about ethics in medical research. It's going to be really interesting for you to read. I'm not sure if you've heard of the Nuremberg Code on page 243, but it was based on World War II. And if you like history, this is going to be really interesting to you. Remember the Nuremberg trials, right? Who tried people for war crimes in World War II? We still actually follow the guidelines of the code issued back then. So this says today, research in the United States that includes human subjects must adhere to the terms of the code that we just talked about, which are largely reflected in the Code of Federal Regulations. Even college students researching the opinions of classmates asking for confidential information for research, right, are required to obtain an institutional review board clearance to proceed. It's so very interesting. Think about how the past has really impacted the future. And I think that's a great thing because when you're dealing with human trials, you want to make sure that you respect their confidentiality. And it's something, of course, that is going to be beneficial for all. You know, clinical trials is something else that is talked about in regards to ethics. You know, there's a lot of drug trials that are out there. And we want to make sure that we take care of people and it's not impacting them in a negative way. And a lot of people who sign up for these trials on the drug side of things understand the risk, and they have to from that perspective. But there has to be a review prior to getting to human subjects. So they go through a process, and the FDA is big into this for drugs. So take a look at that on page 245. Really interesting. Transplants. I want to talk about transplants a little bit. Page 247. I actually did a little bit of work for an organ transplant group in a prior job, and it was very interesting. We had people who needed new organs, right? And it's very, very complex in regards to the confidentiality that's at place, and then also the requirements for the patient to sign off on transplants. Really interesting. I remember sitting in a meeting with a group of providers and some medical experts, and they actually take transplant patients from all over the United States, and this was in Washington, would fly them in and also have to time up where the organ is coming from. So an organ could come from all the way on the East Coast. They fly it in. They only have a certain amount of time, in regards to keeping it ready for another individual's use, and they fly it in and they coordinate all this stuff. So I think organ transplant is a very interesting thing. And from the ethical standpoint, there's a lot of challenges that arise from that and making sure that we're doing the right thing for patients. And there's a really cool graph on page 248, figure 10.1, that talks about organ transplants, all the way from full face transplant in 2010, and then, a pancreas happened in 1966. So we've really made some progress here in regards to doing what we can for patients who have failing organs. Clarify, right? I say organ transplant because that's what I'm used to, but there's non-organ transplants, right, as well. You talk about skin, a lot of bone marrow. There's a lot of different things that are listed in this figure that you can relate to in regards to transplants. Funding. So how is healthcare funded? We talk about that from the perspective of healthcare, and funding for organ transplant is very, very expensive, right? But there's ethics in regards to funding for all kinds of considerations, right? And say a patient comes in that has an insurance payer, say Medicaid as an example, which doesn't pay as much as a commercial payer. That shouldn't play into how we treat patients. And then there's actually laws that prevent, the mistreatment of patients with different insurance or payers, right? If you're taking federal payers, Medicare and Medicaid, especially when I talk about the ED, there's a law called EMTALA. And EMTALA is Emergency Medical and Labor Act. I think it's actually the Emergency Medical Active Treatment and Labor Act. And I might have mixed those up a little bit. But you can look it up. It's EMTALA. That's how we go by. So it says when a patient is presented to the ED, they must be taken care of no matter what their payer is. And it's an emergency situation. So if a patient shows up in an emergency situation, no matter their payer, we have to take care of them and do, it's actually called a medical screening exam. So the screening exam verifies that we've taken care of them, seen what their issue is. We take care of them like we take care of any patient. So actually any patient that shows up needs a medical screening exam by a provider or someone of that magnitude that treats them based on their needs. Two terms used in this lecture that I'm about to use, of course, this lecture, but also your textbook. Autonomy and paternalism. Autonomy is allowing individuals control over themselves. So you hear about this a lot, especially in leadership. I say I practice autonomy as a leader, and that means giving people their own space to make their own decisions. And this can also be seen in patients, right? Giving patients the opportunity to make their own decisions for themselves. Paternalism is providing for people's needs, but giving them no responsibility or control over their own destiny. So we get into the different roles related to that. So, that talks about a gentleman, Billy Best, 16 years of age, was a patient at this cancer institute in Boston when he was informed that he needed 4 months of treatments to wipe out the remaining cancer around his windpipe. He was given an ultimatum by his healthcare providers: continue the chemotherapy or face a painful death. His parents agreed with the healthcare provider and required Billy to continue the treatments at the Cancer Institute. At 16 years, he was considered a minor without the capacity to make the decision for himself. Billy determined he was no longer going to accept chemotherapy and ran away from home, crossing the United States from Boston to Texas. He claimed that the painful treatments were killing him and chose instead a homeopathic drug treatment. His parents, after studying the alternative treatments, agreed with his decision and Billy returned home. A year later, tests revealed the cancer had disappeared. Legally, Billy was unable to make the decision in Massachusetts. Is it ethical to force him to undergo this treatment against his will? Would you petition a change if Billy was 8 years old? What about 14 years old? So at 16, 14, it talks about the age difference there. And there are requirements based on age and treatment, and different states have different requirements as is outlined. But, you want to make sure that you do what's best according to the patient. But patients have a choice. It depends on if it's a minor. There's different instances there, and that's a whole other conversation. But, patients have a choice to do what they want to in regards to their own health and well-being. However, there is a Good Samaritan law, and I want to talk about that real quick, which is not, I don't think, mentioned in this chapter. But when a patient is in trouble, so a patient, has a car accident and is unable to help themselves or say they want help, Good Samaritan law protects healthcare providers for stepping in, taking care of the patient, without them being able to consent to that treatment. So when someone comes in for an emergency situation, a Good Samaritan law is saying the healthcare provider is protected because they couldn't ask the patient. There's a video there for a minute, so if you see a little bit of a gap or if you hear a gap, that's the reason why. I also want you to read the influences on the patient-provider relationship on 257, page 257. It talks about time, and that's really a fee-for-service model, right? A patient comes in to be seen. A provider only has a certain amount of time because he has a number of patients on his schedule, and that's, of course, how the provider gets paid. That's how the organization gets paid. It's access. There is an access issue in the U.S., especially with primary care, that we haven't even began to touch the surface on. Patients can't get in a timely manner, and the issue that's talked about in 257 on page 257 is just highlighting that. From that perspective. So I hope in the U.S. we do a better job of figuring out how to gauge access for healthcare and how to improve it. I think the value-based model is effective. However, there are complications with the payer structure of that. Are commercial payers going to go away? Some commercial payers, of course, participate in value-based systems, as we talked about prior, but how's that going to work? I don't have the answers to that. It's very complex. Healthcare is very complex, but we all know that the United States spends more on healthcare than any other nation in the world. So we have to figure out a way to improve outcomes, and then also, get what we deserve based on our spending. So that's what we hope to do in the near future, and I'm hopeful for that as time goes on. That's really all for Chapter 10. You're also going to have a lecture. Make sure you watch the other lecture that I mentioned earlier in this video. But I hope you enjoyed it. Some of the questions and your review questions will be based on the study questions on page 259, so be sure to look at those as well. If you have any questions, don't hesitate to reach out.